Good morning, everyone. I'm glad to see you here. So we're going to talk about caring for the young adults and teens with Duchenne. I'm Ellen Wagner. I'm with PPMD. I have a great panel here today that is going to talk with you. Once they figure out their seats, they were doing little musical chairs here to start out the morning. So for those of you who don't know me, and I'll have my panelists introduce themselves as they get up to speak, but for those of you who don't know me, I had a son named Tim. He passed away about 4 years ago from Duchenne, and he was 19. So I have sat in your shoes. I understand the difficulties. And I think in some ways, this is the toughest part of Duchenne. It's devastating when you find out about Duchenne, but you have no idea what's ahead of you. And this is a hard road right now. It's a really tough place to be. And you know, we all know the shoulds. We should get better sleep. We should take time for ourselves. We should do yoga. We should exercise. We should eat well. Sure, we should, but how do you do that, right? And how do you not feel guilty about the things that you're not getting done? So each of the panelists are going to talk a little bit about some concrete ideas that you can hopefully incorporate in your own lives. So as I was thinking about this talk over the last few weeks, something came to mind. When my son was diagnosed, somebody sent me a poem from Irma Bombeck. Now, obviously, most of you probably don't even know who that is because I'm old. But she was a columnist many years ago, and she had a really nice wit about her and a lot of satire. So this poem talked about, and it's a little religious, and so I'm going to apologize for that. And if it's not God, it's the greater spirit, whatever you believe in is great. But she talked about how whoever brings children to the earth would choose the parents of children with special needs by how selfish they were. And so this conversation she was having with God, and she said to God, why would you choose that parent? That parent is very self-absorbed. And God's answer, or the higher power, again, whoever you believe in, was whoever is raising this child has to keep a part of themselves to stay alive. And that's really important to us. Like, we have to keep ourselves because you can't care for your child. You know, we all know you get on the plane, you put the oxygen mask on the baby first. It's the same concept. If we are not good, we're not doing the best job for our children. And I don't want to instill any guilt. I don't want to make anybody feel bad. I want really to give you guys concrete information to walk away with. But that poem has always stuck in my head for 20, I don't know, probably 24 years now when I first read it. And it's true. You need a little bit of selfishness to keep afloat. So let's just keep that in mind. And we'll start with Stan, and I'll let Stan introduce himself. And do you guys want to sit as we talk, kind of conversationally? Okay, and we'll do questions at the end. So write them down after each panelist, and we'll have plenty of time at the end to talk about the things and to get your ideas. Because like Stan said, this is where we learn as well. So, Stan?
Very good. Yeah, so I'm Stanley Nelson. I'm multiple things here. So I'm a professor at UCLA. I see patients at UCLA with Duchenne, and I do genetics work. That's my professional life. And here I'm the father of Dylan, who's out and about somewhere with Austin and Max, two of his friends, and he's 21. He's been a full-time wheelchair user since he was 13, is when he transitioned. And so we've experienced sort of this issue of progressive needs that Dylan has faced over the course of this time. And happy to share our journey and sort of how we've gotten to a place where it's manageable. I think, do you want me to talk now, or do you want to
Sure.
get through it? Okay.
Yeah, no, go ahead.
So I would, I'd say my perspective, we did everything for a very long time. We were quite resistant to having strangers in our house all the time. And so Dylan, since he was in middle school and still able to walk a bit, had an aide to drive him to school and back. And that was very similar to our life in LA, right, where everybody gets driven to school, right? And so, sort of after school care and daytime care. And that felt very typical, right? It wasn't so much different than what our non-Duchenne son had. And then the next stage, as Dylan transitioned to a wheelchair, we had to learn all sorts of things. And I would say where we learned them was not from the equipment provider, not from our own clinic, and not from specialists at UCLA, but it really was from other parents a few years ahead in this journey, or sometimes decades ahead in the journey. Simple things like, how do you put pants on, right, when you're in a wheelchair? It's a non-trivial thing. How do you use a wheelchair or a lift appropriately? What sling do you buy, right? All these things. And my back has been going out on me since I was about 21. So you're adding in these multiple lifting things, and we were just doing everything ourselves for a long, long time. And I'd say the pandemic shifted things, but in general, sort of our mode has been to try to hire people to really encourage Dylan to have the independence from us, because otherwise he really had such a close caregiver all the time that it was, I think he's more in charge of his own world now with caregivers that really help provide him, even though it's not mom and dad all the time. But I'd say that's been a sea change in the last couple of years. But,
and I think that's huge for this community. So as boys should be getting their independence, and girls, what's happening is the opposite. And so one of the ways that we can help them along, like Stan said, is find them a caregiver. Take a step back and save ourselves, save our backs, and see what we can do to foster independence.
Yeah, I think our mindful idea is that we want to be there for the enjoyable, social, fun interactions, and not there for just the heavy lifting that occurs a lot. But we're there all the time, so we're always the backup. So I think that's maybe somewhat inevitable. But.
Well, and sometimes I think when it's somebody else, it takes the emotion out. When it's mom, they're yelling at you, you're not holding them right, you didn't have the shower right, the water's not right, it's not the right shampoo. I don't know, the bazillion things that are just a little bit off that you're just in trouble over. And suddenly a stranger comes in and they don't open their mouth. And you think to yourself, where did my kid go, right? And so that's another advantage. I don't know if you see that with Dylan, but I think that's a common complaint in this population.
That's a very fair statement, yeah. And I think the other sort of dimension is sort of this structure to provide support so people can stay in the home is shifting over time, and sort of its accessibility. I'm familiar with California, kind of living the experience. So each of us learns these things and learns them differently in different states and actually in different counties. So it's quite a challenge to kind of work this through to get some support for some of these components that are quite burdensome, right? And so I think I would encourage all of you to be advocating in your state. I think that most of our leaders don't understand this particular slice of the pie. It's a pretty big slice of the pie, but they understand it as it's money spent as opposed to money saved. So, anyways.
Exactly. Eric?
Hi, everybody. So I'm pinch hitting for Natalie Truba today, who is a clinical psychologist, and that's my role is a little bit different. I'm at UC Davis. I'm in the physical medicine and rehabilitation department, and I'm what they call a developmentalist, which both in pediatric and the adult world, I always thought that was a funny name because developmentalist sounds like I'm going to pull a rabbit out of a hat or something like that. But essentially, we look at things from a standpoint of who's looked at the care considerations papers that were in the CDC, the publications that kind of talk about the different care standards across the lifespan and things that people should think about when caring for someone with a dystrophinopathy. There's that one graph that shows that sort of the dot in the middle, that's the person, and then there's all the care team built around it. And so we think about that from a daily life standpoint, right? Which is that you've got the person who's the focus of whatever your caregiving is, and then family around that, and then extended family, and then community, and then your overall larger environment that you live in. So we try to think about where the person fits in their sort of basic environment relative to the resources that you have at hand. And it's not just patient-centric, but it's a family-centric kind of model. And the idea is to think about how these things, if you can sort of fill up that plate with all of the different resources within the home, outside the home, in the school systems, with government, state and government, federal resources, how does that support the individual and the family? And how do those needs and how do those resources need to change over time? And that may be change over time according to the progression of what we learn from a practice standpoint and care standards, but it also could be a change over time in the individual and family's needs based on their age and their developmental status, or it could be their age and developmental status and the degree of progression of their disease. So these are all the things that we sort of think about. And in each of those kinds of situations, you can kind of brainstorm things that are going to be frustrating for parents, or are going to cause parent stress or cause challenges with interaction between the individual and the family, or the family and the outside world, and that those may be different over time. So a lot of what people ask me to talk about, and one of the main thrusts of the research that I do, is in what people kind of tend to call quality of life, right? And in saying that in the past, over the many years, we've thought a lot about calling quality of life mobility, and we kind of understand now that mobility and quality of life are they're related, but they're also somewhat separate. And this is where trying to identify those things that are more associated with a positive self-image and happiness and those kinds of things are how those intersect with mobility. And that could be, reducing barriers for people for school, or reducing stress on parents and the family by introducing outside resources, or by educating the wider family about strengths and limitations of an individual in the family with the dystrophinopathy. So those are the kinds of things that I think about and that we try to apply in a way that is helpful for folks across the lifespan, not just for patients and people with dystrophinopathies, but for families overall. So I'm happy to take any questions if you've been thinking about those kinds of things.
Okay, and Sue?
I'm Sue Apkon. I am a pediatric rehabilitation physician at Children's Hospital Colorado. And in our clinic, I wear a couple of different hats. So I may act in some visits as a neuromuscular doc, so talking about things like steroids in the heart and lungs and sort of routine medical care. And sometimes I'll wear my sort of just straightforward rehab hat. Rehab docs are incredibly practical, and so I think, Ellen, you had asked me to talk a little bit about some of the kind of the practical ideas that in many ways families have shared with me, and hopefully maybe I've shared with them a little bit. I want to go back, though, before I do that, to one of your comments, Ellen. You said one of the challenges as kids with Duchenne, boys with Duchenne, are transitioning from kind of childhood to young adulthood, is normally developmentally the time where you separate. And you comment on this, you separate, right? You start going out on your own with your friends. You may leave the house and live away from your parents, whether it's on a college campus or in a different state getting a job. But the reverse happens in the setting of Duchenne. Right? At that time, things are getting more difficult. You're requiring more hands-on, more assistance. And so from a parent perspective, and really from a kid perspective, the thought of separation might feel overwhelming. And so I think that context, again, is just super important. So from a practical standpoint, and Stan, you alluded to this, you said since you were 21, you've had back pain. The number of parents, caregivers who come into our clinic who have complaints of neck pain or shoulder pain or back pain is tremendous. Just a quick show of hands if you're a caregiver, if you're comfortable, just raising your hand if you've had any back pain, shoulder pain, neck pain, yeah. Yes, yeah. It's common, right? You're doing things that your body wasn't meant to do. And so thinking about ways that you as a caregiver can try to minimize the stresses and strains on your skeleton, on your musculoskeletal system. So working with a physical therapist is kind of something that you may have actually done when your kids were very young. But then sometimes therapy goes away. And what I would argue is that as kids are transitioning to more of a full-time wheelchair user, then thinking about the time to bring PT back in. How can the PT work with you as a caregiver to make sure that you are doing your lifting, positioning, dressing, undressing, transfers in a way that you're saving your neck, your shoulders, and your back. And so asking for someone, and not going to a clinic necessarily, that's a little bit less practical, right? You're not transferring your kid onto a toilet in a clinic setting. You're doing in your home. And my bathroom is going to look very different than everyone else's bathroom. And so doing it in the space in which you are living is important. Take advantage of the equipment that we sometimes talk about. Equipment like a lift system. They're big, they're cumbersome, they're not perfect, but they do have the ability to help save on your neck, your shoulders, and your back. There's lots of different lift systems, so I would say the same thing. Have someone come out to your house with various options and look to see if it makes sense in your own home. What works for you is not going to necessarily work for you, Stan. And so making sure that as you're looking at equipment. Let me ask another with a show of hands. How many people have a Hoyer but don't use it? Yeah, that's been my experience. So it sits in the garage, it sits in the corner of your kid's room. It becomes a closet where you're hanging things. I mean, they're not used as frequently as I think. As a rehab doc, I would like to see them used, and I get it. I mean, it's an extra step. Actually, it's probably 3 extra steps, and it's uncomfortable. And so thinking about even once a day, maybe start with once a week, twice a week, once a day, and pulling that Hoyer out and using it. That will save you over years, that stress and strain on your neck, your back, and your shoulders. Utilize the equipment that you already have, maybe in different ways. So if you're doing transfers from a bed that's low but has the ability to be raised up, doing a level transfer, or actually an unlevel transfer, so higher bed to lower chair, you're using gravity, or vice versa. If your child or young adult or adult has a chair that has a seat elevator, having that seat higher as you're transferring to a lower surface, again, is easier. So those are just a couple of ideas. I know insurance companies balk when I write a prescription for a seat elevator or a hospital bed that the child themselves can use on their own. But there are really good reasons to use that type of to obtain that type of equipment. And sometimes it takes a couple of extra lines within the letter of medical necessity to describe to the payer why it's necessary. Now, I will say, I don't write, it's going to save the parent's back, or it's dad has shoulder problems, and so therefore I need to get this child something that raises or lowers. That will not go over, sadly, right? Because the insurer, the payer, only wants to pay for the person that's going to be using the device and sort of forgets about the others that are going to be impacted. I would argue that's kind of craziness. So you just have to work with your either physical therapist or rehab physician or whoever's helping you to write those letters, kind of making sure that those letters are compelling. I talk about safety. If the child is unable to be transferred safely, they will fall, they will break their leg, and they may have medical complications as a result. And so, while it's a little uncomfortable maybe as a parent to read that, or for me to write it, those are the kinds of statements that are important to have in the letters to get those pieces of equipment approved. The other thing, and actually I was talking to Terry Carey, and so Terry's a physical therapist with 40 years of experience in our clinic at Children's Colorado, and I asked her for her advice because she has seen and done everything, and she talked about a hospital bed. So if you are a caregiver who's having to wake up multiple times a night to adjust your child or your son because they can't position themselves, hospital beds that have the ability to rotate, or again, that person in the bed has the ability to control the position of the back or the legs or whatever, then that can reduce the number of times that you as a caregiver are getting up to reposition. They're not perfect. Some of them are alternating pressure mattresses. Those are kind of cool. So sometimes just even a little bit of a change in position is enough to keep someone comfortable and asleep. So those are my thoughts. I'm happy to answer questions as we open up the panel.
Thank you. And I just want to add, as you talk about fighting with insurance, and sometimes you can get them to pay and sometimes you can't, but often if you go out to your local Lions Club or local civic organizations, this is the kind of thing that they raise money to help with. And so don't be shy to go to a meeting and say, look, insurance has denied me, this is my situation, what can you guys do?
And I would actually add, Ellen, that's a fabulous point. I talked about the guys with the funny hats, right? So all the service organizations. Yeah. They, I mean, and Boy Scouts, so for ramps and things like that, Eagle Scouts have projects that they have to accomplish. So there are awesome opportunities to tap into. You just need to sort of, identify them. The other thing I'll say is, depending on the state in which you live, the county in which you live, there are grants from insurance companies, state Medicaid. So many people will have a primary insurance, so Anthem, and then they'll have Medicaid as a backup. Medicaid, at least in the state of Colorado, has a one-time grant for home renovation. And so you are able to renovate your bathroom with the old-style tub into a roll-in shower space, and that alone can make a tremendous difference. So you transfer from bed to a roll-in shower chair, and then whisk the person into the bath, to the shower for them to bathe. And so again, that's just another resource to think about.
And a comfortable shower chair is everything. You find the right shower chair and you have found nirvana. There's nothing better than getting the right shower chair. I'll just tell you from experience. Colleen?
Hi guys, I'm Colleen Labbadia. I'm from Orlando, Florida, and live there with my husband and our 3 kids, and my middle son, Brendan, has Duchenne. He's gonna be 12 in just a couple weeks. I know many of you can probably understand where we are in our journey, where he's transitioning more to full-time wheelchair use. So I completely understand what Sue is saying. And as much as the physical part of it is hard on our bodies, right? And we can recognize that. The emotional piece and the psychological piece is so big as well. And I think as moms, dads, caregivers, that's just something we push under the rug, right? I mean, I am so guilty of it, so guilty of it. Yep, I'll get to it. Yep, I'll give myself a spa day. It's hard, right? And I'm a counselor by trade, and I get counseling because it's just something that I believe in. It's so important to me. And working on my mental wellness has always been huge. And one thing she asks me every session, what have you done for yourself? I'm like, well, I took a shower by myself. And she's like, no, it doesn't count. And she's great. She knows me well enough that she gives me homework. I want you to go to Target, and I want you to just go in and buy yourself something. Don't buy anything for anybody else. Very hard. If you guys ever want to try it, go ahead. Very hard. But it's little things like that that we look at and like, okay, this is going to be a long journey. So I do everything to help Brendan. I do everything to get my other kids situated and make things as easy as possible, but often neglect ourselves. And one thing that I have found that I think I treat myself to is the tribe I surround myself with. Early on, my husband and I made a pact, like when we came to our first PPMD conference, that it was the 2 of us. Like, we had to lock arms. We had to be on the same page. We had to be able to talk about things, the good and the bad, the happy and the sad, everything, because neither one of us could do this alone. And if we were gonna do this for our kids, we had to do it together. But I also recognize that's hard too, right? I mean, there's times where, Chris is in his mode where he's gotta do the emoting and things like that. And sometimes I feel bad dumping my stuff on there. So within my tribe, I have a great core of friends that I can, call any hour of the day or text or, and that has been such a lifeline. I'm sure many of you can relate to that and have friends or your sisters, your family, anybody who you can reach out to. And, they're the people who can just pick you up when you're down. When Brendan screened for gene therapy and I got the call that he tested positive for the antibodies, which kind of ended our journey there, I was devastated. And, I texted my little group friend, chat, and 15 minutes later, there was a knock at my door. And there was Misty, and she just gave me a hug. And she's like, can I pray with you for a minute? And so there we stood on my Ring doorbell caught. It was so nice. But it was just so nice to have that. I didn't know I needed that, but yet I have this beautiful person in my tribe who thought, oh, I can't do anything for you, but I can hug you, and I can say a quick prayer with you, and maybe that will make things a little lighter. And it was. It's the people we put around us, what they pour into us can make such a difference. And I was afraid when Brendan was first diagnosed. I don't know if you guys feel the same way, but I almost felt bad for my friends, I'm gonna come with a lot of baggage. There's gonna be highs, there's gonna be lower. Are people gonna wanna stick around and go through this with me? And they have leaps and bounds. I mean, my sisters are great, my parents are great. But part of it, I feel like they have to be, because they're stuck with me forever. But when you have these outside people who really can support you, it makes a world of difference. And not too long ago, another one of my good friends said to me, what you and your family have brought to me and mine has been huge. Showing my kids what resilience looks like, what perseverance looks like, how you can get through a difficult situation and still come out smiling, or how you can, wade these tough waters, but there's so much beauty that you're pulling out of it, and when you have that, it's just something that's irreplaceable. I mean, I was just telling Dr. Nelson, Brendan went to a week of Boy Scout camp, which was so great. I mean, here he is, losing his ambulation, essentially, and these great people rallied around him to make this experience happen for him, right? I mean, he went out, his little chair is dirty as anything. He went whitewater rafting and horseback riding and did all these great things. And I'm so grateful. It's not lost on me that he's able to do stuff like that because of the people we've surrounded ourselves with. So, it's okay to be scared. It's okay to, reevaluate and take a look at who's in your life and who can pour more to it. But it definitely brings the beauty out. So, yeah.
Thank you.
You are welcome.
And I think it's important to remember that it's great to have friends with Duchenne and something in common, but that's not always who's around us in our regular life. And it's okay to let those in that don't share Duchenne. It turns out that usually your friends are good with it. I mean, my friends tease me. They're like, no matter what goes on in my life, you always have more drama. I don't know that I want to be the one with the most drama, but it gives them perspective, then okay, I'll take the role on, right? But it's important to really build that support system, I think. And my microphone is, I don't know, too close or something. It's my favorite part of coming to conference. And to be honest with you, it's why I work for PPMD. When I lost him, I thought to myself, how can I never see these people again, right? I see them once a year at a conference. How can I not come back? So I came back, and it was here 4 years ago. And I ran into someone who I didn't know and met, and she had just lost her son. And we sat in the pool and we cried for like 4 hours. I went home from the conference. My husband's like, wow, you're really sporting a tan. Did you go to any sessions? I was like, not really. But I saw my people. And like whoever you surround you with, your people are just so important. Mm-hmm. And for anyone who's interested, our people will be at the pool again tonight, 7:30, 8 o'clock. Come show up. We had a lot of fun last night. So like that's really important. So I think we'll open it up for questions. Brian, do we have anything from?
No, there's nothing yet.
Okay. So what do you guys want to talk about? There's a microphone there if you can walk up. If you want to yell, we'll try to listen.
And you're so right, Ellen. This community is amazing. And I'm sure you guys all feel that way too. I feel like every 6 months, like I get my bucket refilled coming here and then going to DC for advocacy. And there's nothing like this dynamic and what we get out of each other and learning just different things, or having someone tell you it's okay to not be okay, or recognizing we have back pain, or all those different things. There's just such an element we take away from these gatherings with all of us who go through the same thing that just means so much, or even just a few hours at the pool that just, like I said to you, it's much needed, and oh my gosh, I feel great.
And sitting on the stage with people like that are sitting next to me that are amazing. Where do you get to go and sit with these brilliant clinicians and researchers and have a one-on-one conversation and realize they're actually human? Like, they don't seem like it in clinic, but they're really human, and that's a great thing to learn. I think we have a couple questions here.
Hi, my name's Maria. My son, who has Duchenne, is 22. His name is Aiden. And I'm listening, and I feel the same way as Colleen and Ellen and probably a lot of you. I have a great support system of friends, and that's what gets me through. But Aiden, my son, like I say, he's 22, but I think in the social aspects, he's probably a good 5 years behind his peers. Like, he's brilliant, he's got all those other components, but the social has always been hard for him, and high school was just not good. I mean, nobody was mean to him, but nobody invited him to a party. Like, it was heartbreaking in a lot of ways. Now he's in college, and he's much more involved. He's in a fraternity, and he has a good group of friends, and even his friends from out of town, they Zoom sometimes. But still, he's not quite, like my older sons, they just go out, they just hang out, they just do things, and it's always a little harder for Aiden to engage socially or to, and he's usually if he does want to hang out with people, he's the one who has to instigate it in most times. So I'd just like to hear more about if your sons do have a great social life, like how did you help them with that? Is that just something that came naturally to them? Like for me, I look at Aiden's life, and he's got a lot of wonderful, great things going on right now, but it's that social component that I wish he had a stronger friend group, because we said how much that means to us. I would like him to have that too.
I think that's a great question. Eric, do you want to take that?
I don't have direct personal experience with this, but I think something that you said, and it's clear when I hear parents talk about having young men or young women with dystrophinopathies who are out and becoming their own adults, that parents have done a great job of helping them to maximize their potential for developing autonomy from the parents. And so I'm always amazed at how well parents do at kind of letting go at a time where, like Sue said, it's a time where here are folks who would be off out in the neighborhood with other kids, and yet they're closer to home and require more help and more physical help. So I always encourage people to think about, like, what are you doing in your daily life for even your 10 or 11 or 12-year-old to help them maximize their level of independence, because that's going to lead to them becoming independent adults to the best of their ability. And so I want to congratulate you for getting to that point. I think that's fantastic. But it is something that I tend to just encourage people to think about. There's no right or wrong, because everybody's different. But that there are, the one thing I'll add to that is that through developing autonomy and helping to develop adult roles, that is in some ways a way to reduce caregiver stress as well. And it's difficult still to have your child go out into the world and not be able to monitor them and make sure that they're 100% okay all the time. And for people with mobility disorders or disabilities, it's even more so. But anyway, so congratulations and thank you. But I'll defer to the parents in the room for the rest of that.
I think many of us have the same experience as the speaker did. I think we're sort of in a mode where, as the physical challenges get greater, sort of you're in different, middle school, elementary school is different than middle school, right? Friend groups often change. Middle school is different than high school. High school is different than college. But, for those of us that are sort of having typical development, it's tough enough. And then you throw in kind of this huge barrier of the wheelchair and some personality issues that do happen. And I'd say Dylan has had a steadily peeling away social group, which is really quite painful to watch. he's quite resilient in some ways dealing with it, but I don't think that we get to necessarily solve that for them, right? It's sort of this issue of preparing for independence. My hope for Dylan is, it's a little bit, we meet people at work, we meet people at school, we meet people when we're out doing the things that interest us. And I think for Dylan, my attitude would be to encourage him to sort of want those things, to be out and about, to be taking classes again, to be working a job, doing things, volunteering. He has a vision of some things that he'd like to try to do, which is great. And just encourage him to do those things. And that's where he'll meet the other people who are like-minded, because it's hard to find the like-minded people. I mean, some people are blessed with that in their families, others are blessed with that in their sort of their local friend groups. Others, I have friends who have high school friends who are still in their lives at 60, which is remarkable to me in some ways. And everything is a bit different and customized. And so I think it's kind of, but you can't make it happen for your 21, 22-year-old per se, right? So I think it's very challenging.
It is, and I see that with Brendan now. He doesn't like to, invite people. He'll just sit and wait, but then gets down on himself because nobody's calling, nobody wants to go here or there. The silver lining there has been, I have a 13-year-old daughter who wants to go everywhere and do all the things, and once in a while he'll say, that looks really fun. Like, okay, happy to drive you if you want to call somebody's. I will, bring you guys, happy to stay with you. And that's kind of been the push. He's kind of just modeling after her. I mean, I don't know if that works for everybody, but it is something that I do know is coming, and it's hard. It's hard.
Yeah. Well, that's great to have a model in the household, especially with sibs who get along and can one can tag after the other. That's fantastic. And I think people should understand, and I'll talk about this a little bit later today, is that it's been long understood that people with DMD have maybe a little less social drive to interact with others, and that's. When we talk about the Dmd Behavioral Phenotype, sort of colloquially, that's that. But that's evident from sort of early childhood, and it's just something that seems to be a common trait. And it doesn't mean that it's a fixed thing, and it doesn't mean that that new strategies can't be learned. It just means that it takes a little more challenging to learn those skills. And we see that across lots of groups of developing teens, not just people with dystrophinopathies. And so there are, even through counseling groups and things like that, for folks who may have where it may be painfully difficult to interact with new other people. Those are things to talk to your care team about whether there are resources to get them into kind of coaching situations or ways for them to develop strategies that they can use to meet new people, to talk to them, to initiate conversations. And not everybody needs that, but some people definitely do. And it's not just, that's true across multiple different developmental disorders as well, and in the regular, typical adult population. So anyway, if that is a concern, just know that there are resources that you can search for, and your care teams will be a good place to start to help to find those kinds of resources.
I think there was a comment here.
Hi, my name is Lisa, and my son is Charlie. He's 26, and I think there's no right or wrong with this parenting of boy with Duchenne. But when I look at things that I wish I would have done differently, I just wanted to share. Maybe it'll help somebody else. For us, Charlie's really shy, and so I'm really more outward. If you can't tell, I'm like, I want to talk to you. So I thought, he should be social. He should be doing this. He should be doing that. And so his whole life, I tried to push him out into being somebody that maybe he wasn't. So, he went to college and he stayed in a dorm with his buddies from high school and he was in a band. And, as he may have enjoyed that experience, but also at the same time now, when he's 26, the greatest gift I've given myself as a caretaker and him as my son, I think, is letting go. I'm taking courses in codependence and just letting go and letting him be his own person. I mean, I went and I got him a life coach and psychology and medication, trying to do as much as I thought I could for him to be the person I thought he should be. But now at this age, I'm stepping back and I'm relieved to know that and speaking of a higher power, so I let go and I let God work in his life, and I pray for him, I give him that gift, and let him be his own person. And he got on his own. I told him about this volunteer position that was available at the fire department that he's going to now, so he's doing things on his own. And also I feel like that gives him a feeling that I trust him to make his own decisions and a confidence within himself, instead of me. I feel like I beat him up all these years, like, you're not enough. You should be doing this. You should be doing that. Not saying it, but making him feel like he should be somebody that he's not. So I shared that my mistake with y'all, and I don't know if that applies to anybody, but we're doing better now. The more better I get, the better he gets, if that makes sense.
Absolutely, and we all have different personalities, and just watching even normally developing siblings grow up, they all have different personalities. And you think to yourself, how did they come from the same genetic pool in the same house? And they're completely different. And then, of course, you throw Duchenne in, and all bets are off. I think Gretchen has a question. It's hard to see with the light, so I apologize if I can't tell who it is.
So I'm glowing with the light behind me. My son Nick is 23, and he lives with caregivers who are his friends, so we're in that fortunate position. I would drag him to conference, trying to make him more social, get out there, and there was a quarterbacking your care session that I made him go to, and so we would use this phrase that we hijacked from PPMD, quarterbacking your care, gotta quarterback your care, and he has sometimes talked about me throwing him to the wolves, but he is more independent. And so with COVID times, he was in his apartment, had some virtual visits with clinicians, and because of the way things are with privacy, he has his MyChart, he has his things, he has had his caregivers drive him to some visits. But I have always been the primary person responsible for his care, and I will still field those things that as a 23-year-old boy man, he doesn't always take the time for. And so I'm wondering, as you are seeing more adults in clinic and men who are more on their own, what advice do you have to us to keep from for them to not flail at some point? I know I need to do something so that, I guess, I don't need to be his power of attorney, I don't need to be his guardian, but I need to have some things in place. Just in general, what do you recommend we should do or make sure we don't do?
I'll chime in here. I think it's a tough issue, actually, because you're right, guardianship is often not the right answer, and it's sort of against sort of a lot of the discussion we've been having, right? So you do want to maximize independence. And we have, in our clinic, we have some adults who really have no, adults with Duchenne who have no other family member coming with them and to clinic, and with a care provider on event, and very, very independent, and it's their clinic visit day, and there's no information shared with any other family member. So there's that category of person absolutely exists. I find it hard to imagine Dylan in that exact situation, to be quite frank. And I feel a little bit simpatico with you, as I feel like I would always want to know, and I'd always want to be fine-tuning some decisions. Is that my right to always do? No. But is it worthwhile to keep that connection? Absolutely. So, but at the same breath, in the same clinic, we also have 23, 24, 25, 26-year-olds coming with often the main other parent, often, who's sort of helping in all decision-making. And there's quite a breadth of kind of decision-making capabilities amongst those with Duchenne. So I think each family's kind of adjusting to what works for them, because if the person with DMD came back home and others are involved in the care, and has a difficult time sharing what information was just learned or what changes are going to occur, that's not a workable situation, right? Because you then basically have lost meaningful medical care. But we have everything in between, honestly. And some kids absolutely do, well, some adults need guardianship, so that does happen as well. So it's really quite the breadth of things. I would say for the average, it's a bit more like your family. And I think as a care provider, I would rather give that information directly to the person that's receiving the care than to the caregiver to interpret for me to that patient. But it's fluid. It's really quite difficult because the major issue is communicating what needs to happen for that individual to give sound medical advice and guidance and make sure that information is received. And this is probably more generically true across everything in medicine. I would argue not to throw my father-in-law under the bus, but when I sort of, if he communicates some of his medical issues to me as his son-in-law who has a medical degree, it can be quite garbled, right? It is not necessarily absorbed in a way because it's affecting you. And my own father, who's a physician as well, there's a real benefit of having somebody who's not affected, who's a compassionate, thoughtful human, who can actually interpret some of the information. So actually, if I was in King of the World, I would actually like that model for much of it when there's a benefit to it, but always respecting the patient's autonomy for decision making. So
Yeah.
There's a long-winded description, but
No, I think, Stan, your comments are really, they resonate with me, and I think the discussion or the comments you made about your father-in-law, I think especially resonated with me because as a rehab doc, I take care of people who have congenital or born with conditions like Duchenne, and so they are receiving care at a very young age with parents that are always there or caregivers. And you, as the caregiver, are the one who is really leading that. And on the other hand, I take care of kids and adults who have acquired disabilities. So someone who acquired a spinal cord injury as a 25-year-old or a 26-year-old. And in many ways, it's easier, I think, for me to see those people with acquired injuries separating from caregivers and being autonomous and showing up on their own and transferring the information however they choose to transfer it. And I wonder, and I'm going to pose this to all of you, but I wonder if it's more challenging when you have been the caregiver since day one and that separation. But I think that what's similar about the two is that they're 25-year-old adults, young adults who have the capacity to make their own decisions, and should they choose to share or not share information that was, discussed in the medical setting is really up to them. The caveat, as many of you or some of you may know, is in the setting of Duchenne, there are some men who will not have that capacity because of an intellectual disability that won't be able to assume full responsibility, so guardianship, and therefore coming to appointments and all of that is necessary. But if you have a son who was able to navigate high school, college, live on their own, then they should be able to navigate their health care, perhaps like other 25-year-olds who maybe don't do it great, and they pick and choose what they want to do and when they want to go out and get an appointment. So some of this actually may not be Duchenne, it may actually just be young adults not wanting to have insurance and health care and craziness like that. So, and I would love to hear other people's comments, because I think, yes.
I agree, and I think as we are, the ultimate goal is to have these kids live as long as possible. So my advice, and I didn't do well, we were talking about our mistakes. Get services and supports early. You may not think you need them when you have to start the processes early. And these boys are going to have to rely on outside caregivers, outside the family. So it's good to get them used to that as early as possible. It's really good for the
the AAP, American Academy of Pediatrics, talks a lot about transition. And it really, as a pediatrician, I should be having visits with youth starting at about age 13. So kicking parents, caregivers out of the room and having conversations with them. I oftentimes like to give homework to teenagers, and really it's the homework for the parent to basically back off a little bit. Meaning, if the child's wheelchair needs repairs, giving them the tools to make that phone call to set up the appointment. Ordering medications, it's all online. The kids probably can do it better than you anyways. Giving them some opportunities to do some of these even little things where you're still supervising, but giving them the opportunity to do these things on behalf of themselves, giving them that autonomy to do these things, and starting at a really young age, and gradually building upon that. Hopefully it will lead to youth or young adults that are a bit more independent.
I think so. I'm the parent of a young adult with some chronic health issues, and that we identified right around 12, 13 years of age. And I actually learned a lot from a model, a care model that we were put into as a family, where he had all of his own independent physician visits, and we had kind of a parallel visit where we were taught the information that he was going to be given. And it was a little bit nervous knowing that all this, his behavior was what was going to keep him out of the hospital, not us. And we could nag him and we could do that for him for a certain period of time, but they said he needs to learn to do this for his life, for his lifetime. And so if you're worried that he's not learning these things, what you can do after these visits is sit down with them and say, so what did you learn today? Here are the topics we're going to go over. Tell us what you learned about relaxation, or tell us what you learned about dietary management. And that way you get a chance for him to reflect out loud back about what he's understood from his physician's visit. But that was kind of the extent of the physician interaction that we had. And I thought that was a fantastic model. Now that he is out on his own, sometimes I definitely have that urge to quarterback. And I have had those conversations about, well, do you think this decision is, what's going to happen if this lands you in the hospital? But purely from have you thought about this as, since you're in charge of yourself? And it's definitely challenging as a parent. So, but that idea of talking to them and kind of getting them to teach you what they know, I found was pretty eye-opening, and wasn't something I would have necessarily, even having been in the clinical world for years and years, wouldn't have necessarily appreciated on my own. So we all have stuff to learn.
I think another thing, I'll get to you in 1 second, Brian. I think another thing that we all can do is many of our children have aides, even going back to the elementary level. And it's really important to start to teach them at that level, how do they work with their aide in school? How do they say, I need you to pick up your pencil, but I don't want you to sit next to me at lunch? Or I understand you have to be on the playground, but can you give me 10 feet? And do it kindly and with courtesy and be thankful, but set your expectations. And I think if you start, the younger we start, the better all of us can be. And again, I speak from experience. We didn't start soon enough, so we get to high school and we have this kid who's really basically a brat. At one point, I got a call from his teacher who said his aide is doing all of his homework again. I said, how do you know? Well, the aide doesn't actually write as well as your son. Okay. We'll have to work on it. So, but I think even from a young age, if we can start that expectation of managing their life, and I have a almost 30-year-old son who's not affected with Duchenne, and I will just say, parenting adult children is just difficult. I don't care if they have Duchenne or they don't. I frequently say to him, so if I were in your shoes, I might think about this and this and this as the consequences of what you're telling me. And the best I ever get is, oh, good call. So once in a while, it sinks in.
Nice.
Brian?
Sorry,
So there are some remote questions.
Oh, great.
Which one is a comment. The suggestion is that a lot of states have caregiver resources, nonprofits that support caregivers and helps them to manage that aspect in their life. But I'm going to tie a couple of questions together, and beginning with the suggestion that caregiver self-care is actually part of caregiving. It's not an absence of giving care. You've got to take care of yourself. I think it's based on your Irma Bombeck comments earlier that amplifies it. But additionally, there are questions about our clinics providing some sort of guidance to families about caregivers, and what can clinics do to support caregivers in that phase where they need to start stepping back. I have the experience of having a daughter with type 1 diabetes. She began managing her care at age 8, so our model for Duchenne was sort of like an adaptation of that. We allowed our sons to participate more in their clinical care at an earlier age, but not every parent, because of the enormity of Duchenne, do that. So the question is how do clinics support that, and how do they also support caregivers?
So it's a great question, Brian. In our
Could
Never
you
Clinic.
please repeat the question for the people
Sure.
on
So
Zoom?
the question from someone wrote was around how do clinics best support caregivers in this idea of helping their sons be more independent. Is that a good summary? I have a couple of thoughts. My first comment is we don't always do it well, and that's hard to say. I think it takes a lot of intentionality to really focus on transition. I think that there are PPMD and other organizations have kind of transition checklists and things like that. So things that we could use as providers or families could use to make sure that that you're sort of accomplishing those tasks. I know our hospital has a lot of work right now going into helping across all different conditions in departments and specialties, helping us as providers to transition kids into the adult world. And I want to sort of make a comment. Transition and transfer of care are very different. So transition, I believe, is really what we're talking about, is helping youth become independent, autonomous in their medical care and in life. That's transition. Transfer is merely the act of moving from one pediatric provider to an adult provider. That's a little less exciting. There's some challenges with that, but that's really the transfer. The transition is really what we're talking about starting at age 13. How can we help youth become more independent? In terms of support within the clinic settings for caregivers, I think social work is super important. PPMD has the care centers, and as part of being a dedicated care center, you have to really have a social worker there that can help support the whole family. It's not really just about the child. And the social worker, and in our case, we also have a health navigator that really can help people understand what resources are available. The comment that was made earlier around states have, or cities, counties have resources to help with caregiver training is actually something that's really important to learn about. And everyone does it a little bit differently. But there are skills that are needed to be a successful person who relies on other people to take care of them, right? You can get away with being snarky with your family. You cannot get away with being snarky or inappropriate or rude with a paid caregiver. And so there's a lot of work that goes into training people on how to best deliver that.
And we've had a great experience at clinic. Brendan's neurologist has been wonderful. And from a very early age, we'll directly ask him questions. Yeah. And sometimes Brendan will look at me and I'm like, nope, look at Dr. Finkel, go ahead, he asked you. And then there's some times where he'll give me something to do, like fill out a questionnaire or something where Brendan sees that I'm tied up. So he's not gonna look over to me. He's just gonna sit with his doctor and ask. And I've always appreciated that because from the time all of my kids were little, I've really encouraged them to advocate for themselves. Do you need a tissue? Go ask your teacher. Or you lost your math homework, you're gonna have to go in and let them know. Those kinds of things. But I will say his neurologist is also very good at reading me. You know, I remember once he asked the nurse to take Brendan down to go get blood work and close the door. He's like, "Are you okay?" I'm like, "Oh yeah, I'm fine. I'm fine." And he just looked at me, "How are you?" And I'm like, "I'm not fine." You know, but he knew that enough and talked to me about, am I taking care of myself? I'm doing a great job taking care of this little guy, but what am I doing for me? And having those kinds of conversations, it was hard, you know, and I felt a little embarrassed. And he's like, "Don't be embarrassed. That's what I'm here for. And I'm going to guide you through all these different stages." And I just appreciated it more than he probably will ever know. So,
We're here to take care of kids, but kids come with families. And I think to one of your very first points, you know, you have to take care of yourself in order to be able to take care of your kid. And so as a provider, we really do have to pay attention to the whole family.
I wish Natalie was here today to talk, because and a lot of what we had a conversation just last week, and a lot of what she was talking about was management of anxiety as well. And you know, anxiety being one of the, you know, a challenge for a lot of people with dystrophinopathies that impacts a lot of different areas. It's not just how you feel, but it also impacts how you interact with others, and especially if you think about clinical situations where, you know, you have that like white coat hypertension idea. Anyway, for most of us, going into a clinical situation is anxiety provoking anyway. And if you start with a higher baseline, it does make it easier for people to shut down, and it's easier for guys and young women with dystrophinopathies to rely on a parent, because the parent says, "Oh, I know they're really anxious in this situation. I'll take over and ask the questions." And I don't say that to blame anybody, but it's a protective response for everybody, right? And but acknowledging that anxiety may be an issue that influences how people interact with their environment and the people around them. As a part of the multidisciplinary care team, we focus so much on mobility and pulmonary function and, you know, all these muscle-related things that sometimes the brain and behavior part we don't always do quite as well at acknowledging, because, you know, visits are, you know, you got to pack everything into an hour or whatever. So I encourage everybody to continue to talk about those anxiety kind of issues and what can we do to help to manage that if it's a challenge, so that you can interact more clearly with folks, ask questions, communicate for yourself, those kinds of things.
Another thing that I think happens as parents is we start when these kids are really little, and we really get to know these practitioners, and we get kind of attached. And so you go in and you haven't seen them in 6 months, and you have to catch up. You know, how's this, how's that? Well, the kid's just sitting there. My son said to me one day, "Why do I come? They don't want to talk to me, they like you." And that's my fault, really. I was like, wow, I have to shut up and let him be the focus. But when they're little, they're not old enough to speak for themselves. And so you do start to build this rapport, which is great, but we do, as parents, have to remember to let the kids talk. Kathy.
Hi. The other thing that also often gets skirted in these visits and at home is puberty. So I've noticed that although muscles maybe not work, the hormones do. So could you guys talk about how you manage with puberty and all the adolescent developmental issues and privacy and sexuality and all those things that nobody wants to talk about, but your teens and young adults are thinking about every 5 minutes?
Right. Sex, drugs, and rock and roll.
Good question.
Yeah, I'm happy to start the conversation. Stan, I would love to get your input as well. So, yeah, I mean, that's one of the reasons why having youth having a separate visit with their provider gives them an opportunity to either ask questions or me to ask questions of them around these issues. So puberty, I will say, we talk about all the time in the context of steroids, right? Corticosteroids, whether it's prednisone, deflazacort, will delay puberty in many cases. And so we are asking those questions. We refer most of our youth to an endocrinologist who helps to manage that. Testosterone is something that, you know, is used very frequently to jumpstart puberty and with really good benefit. So I think that the sort of the puberty part, the medical side of puberty and the changes that are seen, I think we probably have a good handle on. The issue around the sexuality piece is, I think, much more challenging. And again, I will sort of say I'm not the bestest at doing that, whether it's my own discomfort with it or frequently when I ask the question, actually, because I oftentimes do, I'm met with a little bit of a blank stare, and it may be that the youth is, it's the first time someone's asked them that question, and are not quite sure how to answer. I oftentimes ask just to ask a little bit about the friends, and it goes back to one of the audience's questions around, my kid doesn't have as many friends or hasn't had as many friends, and I think that that's an important place to start. And talking about the importance of friends. Friends now, it's just sort of this bizarre situation where friends are online. And that certainly in the setting of puberty and kids surfing internets can get themselves into a little bit of trouble. Again, I'm not certainly an expert on that, but helping parents be aware of safety on the internet, I think, is something that is important. I have the privilege of also providing care to men with Duchenne in our young men's clinic, and we have to change the name because they're not young men, and they're younger than I am, but they're well into their 30s. And the question of sexuality and kids, men, wanting to have the experience of having a sexual encounter has come up. At times with parents in the room, other times without. And it's sort of I'm not sure I have a prescription that I can provide. I think it's a conversation that we need to have and be more comfortable having. But it should be discussed, I think, at each visit, whether it's brought up or not.
Yeah, I think it's a challenging area, and it's challenging at home, it's challenging in the clinic, et cetera. So, but I don't want to speak about Dylan's puberty per se. So.
Probably not appropriate.
That would make you Father of the Year now, wouldn't it?
Seriously.
Yeah.
But there's a lot of embarrassment of adolescence, right? And it's true whether we're able-bodied or not, right? I could sear it into my memory are some of my most embarrassing moments. And it's kind of this issue of what are we aiming for, right? And so I think it's we even use the words, we want our kids to be independent, or we're trying to get them to be independent. We want the independence, and we don't really want that, and none of us are independent. We don't want to go live in a cabin in Montana, chopping up, weeds to eat, and that's not the goal, right? We don't be the Unabomber, whatever. But it's different. It really is an interdependence that it's an autonomous interdependence with others. And puberty is kind of part of that, and it's a very different experience. I'd say Dylan's issues were online, both positive and negative. The online experience is a real way to socially connect with people in very meaningful ways. And it's also a way to distribute abuse in various different ways that can sometimes be quite difficult to trim off. And those are then difficult things to kind of guide somebody through who has, who's not having that kind of normal social outlet in high school or in college years. And I certainly don't have any meaningful answers to that at all, other than just, we're all parents and we're going to guide as best we can. But I think my reflection for Dylan is my goal isn't independence in the sense of, he's out of the house and gone, but it's how does he create a social world where he's interdependent with others in a way that's compassionate, thoughtful for his, and mindful of his autonomy to make decisions. And I think it's, we're all in a bit of a different awakening in different areas, honestly. And I think disability rights and disability, access issues, but also it's not just access, it's really providing the resources that our society should provide outside the family that enables integration with society. And we, the cumulative we, don't do a particularly good job of that. So I think
there's a couple of books if people are interested, and I'm going to butcher the name of the one that sits on my bookshelf in my office, which is like the ultimate guide to sexuality and disability, something like that. And it's pretty explicit. in terms of, depending on what kind of physical disability you have or other disability, sort of the act of, of sexual intercourse and things like that. But it's really, it's a great book, and, as a parent maybe of a younger person, or maybe it's a parent of an older person, you want to give that book to them. I think that there's some, interesting maybe pieces of advice in there. But there's a couple other books that I'm aware of, but that was the one that someone had given me to read through, and I thought it was really good. It's like the ultimate guide to sexuality and disability, I think is the name of it. I just handed it actually to, so there was I think it was last night, Richard Schell did a session with men, young adults, and I texted him the name of that book. So if your kid was in that session, they may be online searching it out for themselves.
It's the ultimate guide to sex and disability.
Thank you, Kathy. Author?
By Miriam Kaufman.
Miriam Kaufman is the author?
Yeah.
Thank you.
I think there's another question there. I saw a hand go up.
I'm not right now.
My name's Daryl Knight. Nobody knows. My son Jack. Susan's cringing right now.
Daryl, can you go to the microphone? We got Daryl.
Daryl, can you go to the mic?
Yeah, so the people at home can't hear us. I've gotten that.
Yeah, my name's Daryl Knight. My son Jack goes to see Susan. So I'm Wednesday, I believe. One of the things, he's 21 years of age. He goes to the University of Colorado Boulder. He is a senior. He's got caregivers that take care of him while he's at school. He's done quite well, I think, as an independent adult. But as a parent, when he turned 21 and went to the adult part of the clinic, I was banned from going. Okay, he just didn't want me to. And I guess as a parent, that's what you want, right? I mean, is to be your son being independent and take care of his own care and stuff. But as a parent, you're also going to go, but are you doing it right? That type of deal.
Sure.
Obviously, he has as an adult, he has his rights to his privacy with his doctors and everything else. I wonder if anybody of the other parents feel the same way I do. It's like, is there that sense of loss that you're going, is he doing it right? Should I intervene? Should I do something? And when I ask him, how'd your clinic go? Like I did last night. How'd your clinic go? Great. Want to elaborate on that? No. I'm good. Well, so you kind of wonder, it's like, is he doing this right? And I guess the question there is some of the older boys and the parents that have older boys, did you guys go through this and go, how did you get through it? Because honestly, I'm struggling with it. I'm going, God, I hope he's doing the right thing, But you want your boys or any kids to be independent, right? You want them to take care of themselves. But obviously, boys with Duchenne, you've been doing it for so long, you have that extra little care in there. Does anybody have advice for a new time abandoned father? Maybe?
I think Gretchen always says, what do you say, Gretchen? It's that fine line between the... So I'll repeat it for the people online. There's a fine line between helicopter parenting and neglect, and it's walking that line. And I guess I'll pose a question too to the physicians here. What do you do if you see, and this isn't Jack, but what do you do if you see a young adult come in and they're not doing what they need to be doing and they're not bringing anybody with them? What do you do about that?
Wow, that's a great question. Stan, do you have a...
Way to pass the buck there.
Yeah, so, so I'll answer this in a slightly amorphous way, but it's not ever a mystery to, I'll give you a few scenarios. So sometimes we do see people for the very first time, and they're an adult, and they're coming in, and they've been getting care in the community that I would not have advised. And so we're meeting with the adult with Duchenne and describing the sets of things that we would alter to sort of be giving care in what I would consider an appropriate way, or what our neurologist colleagues would consider an appropriate way. So there's kind of a whole team team discussion. Some of those adults don't have anybody else. It's not, we're all in a bit of a luxurious world here, right? But there are people who are solely responsible for their own care. They're going to make decisions with the sets of skills that they have. And it is the same with every other patient in the universe, right? In terms of, how do you convince them to do what you think is a medical provider, but we respect their autonomy of decision making. So that category of person does exist, relatively rare here, because this is, it's even in the name, parent project, right? So, we are more helicopter parents than we are neglectful parents, for sure. But that transition mode that Daryl was just talking about, most are in that category where we've cared for them. We know the whole family. We know the siblings. Siblings have come in. We know the caregivers. The same caregiver's been coming into clinic for a decade, right? So it's not like there's kind of a mystery to the average. So just to address that situation is if somebody is really making a bad decision, it probably, an instance would be, and this is not so uncommon, can't really put numbers on it, but somebody's actually just not showing up for clinic visits, right? Just didn't get there, didn't arrange transportation, didn't appear. Parents aren't as much coming to the clinic anymore. We would call back to the family, whatever number is on, and we would, address the issue of, that's kind of a bit stark, right? It's not just making bad decisions. You're not seeking any medical care. You're not even showing up for the appointments. And often the parent answers the phone, right? It's not,
right.
They're often living at home. And we do, have the discussion in a sense with the whole family. So it's a bit of an amorphous answer. But the person who's responsible for coming is the adult, with Duchenne. But often the whole family is remaining involved in my experience. So you're kind of having this communal discussion, which is not quite right. But I would argue how we treat teens and sort of creating private teen records isn't right for Duchenne. It's an area that we've adapted for really puberty issues, sexual reproduction issues, privacy issues. That's relevant for the average teenager and less relevant for some rare diseases, but we still apply it. We don't have separate rules. We don't have separate issues. So there's a lot of things that are like that. And I think this is one of those amorphous areas where it's not just the discussion back with the actual medical decision maker, which is the individual. So, but if somebody was making bad medical decisions, it's not. That does happen, right?
Yeah, it really is such a challenging situation. I think, if someone is not competent to make a decision, so I'll use an example of someone with Alzheimer's who's coming on their own. They are not following your instructions. They're coming without caregivers. We have an obligation as physicians to report that to Adult Protective Services. And so I use that example, and I can't even come up with sort of a situation where I've seen that in our adult clinic, where someone came on their own and didn't have the capacity to really make the decisions. Now, they may not have made the decisions that I wanted them to make, but they have the capacity and they've chosen in a thoughtful or in a 25-year-old, guy's mind way to carry out that, that decision. And I think, to your point, Stan, I think families are still typically involved. And so I would the way I personally would address that is if someone was in my clinic and really struggling, so they were there alone or with a caregiver, not a parent, and they were really struggling, even though they have the capacity to make those decisions, I might really encourage them to pull their family in or even ask permission. So I couldn't just call you, Daryl, as an example. That would actually be against HIPAA, which is the Privacy Act. I couldn't just call you to say, hey, I want to talk about your kid. I have some concerns, but of which I did not. Just wanted to say that. I would ask permission, and I would bring in my experts, which are my social workers or maybe my psychologists, to help sort of explore kind of what the barriers are. and really hope to get to the point where I could bring in family members to help support the youth.
Well, you know, we have an older son, and the way we treat him is completely different than the younger one. We let him make those decisions thinking, oh yeah, he's going to make the right ones, even if they do. Well, for some reason, obviously, for the obvious reasons, is we always helicopter the boys with Duchenne when we do the other side.
So
I think we'll take one more question. We're actually already past 10. Go ahead.
I'm Debbie Dupree, and my adult child with Duchenne is 29, and if anybody wants to talk to me, I'm happy to talk to them about how we've handled it. We made the decision through communicating well that I had the passwords to the MyChart, because if there's an emergency, I'm going to be the advocate advocating. And we did have an emergency, and I did have to take control. So we just had a series of conversations, and I don't go in and hover over my chart because we have communications and trust about that. But that is what has worked well. We kind of have a binder of the most current visits, and also if you can get your adult child to put the appointments on a community calendar, that way it's showing them they're being responsible, but you're telling them, I'm trying to let go and you need to work with me here to alleviate my anxiety over letting go. And that's worked really well for us.
Thank you. And thank you, everyone. And thank you to our great panel today. I think most of you are around the rest of the weekend. So if you guys have more questions, reach out. Try not to corner them in the bathroom. Apparently, it's not their favorite place to talk. But beyond that, reach out and have a conversation. So thanks, everyone. Appreciate you being here.